webinar is now streaming live, fellas.
طيب دلوقتي ممكن نبقى دكتور اونلاين ناو. اوكي
اوكي. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. Today we are going to start our third session in a series of 5 sessions of rare disorders. Today we have 3 speakers, and our moderator is Dr. Muhammad Janina. He's professor of pediatrics and pediatric gastroenterology, Cairo University School of Medicine. He's a consultant pediatrician at Saudi German Hospital. He has an interest in IBD with a lot of publications in this one, and in endoscopic management of pediatric esophageal varices by banding and sclerotherapy. تفضل دكتور محمد.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks a lot, Dr. Fawzia, for this very nice introduction. And it really gives me a great pleasure to share with you moderating this session. Today, actually, the 3rd day of the series of webinars dealing with rare pediatric diseases. And the theme of today is amino acid disorder. Actually, the agenda of today will be divided into 2 parts. The first is 3 presentations from our 3 distinguished speakers. Actually, each will take around 20 minutes, and I hope the speakers will stick to the allotted time. This is going to be followed by questions and answers. So the questions will be after completing the 3 sessions. And you can submit your questions in the bottom of the page in the question and answer icon. I don't want to waste your time, so we will start now. Usually we say ladies first, but because we have only 1 male speaker, we must give him some privilege. And I'm really happy to introduce Dr. Zuhair Rahbini. Dr. Zuhair is the chairman of the Department of Medical Genetics, King Faisal Specialist Hospital and Research Center in Riyadh. He has got Arab Board of Pediatrics 1992, Jordanian Board of Pediatrics 1993, American Board of Clinical Genetics 1996, and American Board of Biochemical Genetics 1996. He has a special interest in neonatal screening and prevention of genetic disorders, and he has got more than 50 international publications and more than 50 international presentations. So let's welcome Dr. Zuhair, and now the floor is yours. Kindly share your screen.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. I would like to thank really all organizers for this seminar, and special thanks to Dr. Fawzia and Dr. Muhammad also for nice introduction. My talk will be about newborn screening, how it was started and what is the future. I will talk basically about newborn screening in the kingdom. السلام عليكم ورحمة الله وبركاته. Please smile كما تعرف أن الرسول صلى الله عليه وسلم وهو مثقل بهموم الأمة بأكملها يبتسم ويستعيد من الحزن. Please try to smile during this talk. So my talk basically will be a short introduction, case findings, some history about newborn screening in the world, and the milestone of newborn screening in the kingdom, and how it was started and what is the future. So if we would like to look for a health program in general, newborn screening or cancer screening, whatever, we have to look to this criteria, the principle of early diseases detection, and that this criteria was established by Wilson and Zingner in 1968. However, the principle of this criteria expanded with time, so more criteria added and modified. There is criteria by WHO established in 2008, and as you see, the criteria include many things. The most important things here, there should be scientific evidence of a screening program effectiveness, and the overall benefits of a screening should outweigh the harm. So this is basically so you have to look for your diseases, prevent these diseases, and it should be cost effective. Also, the most important things in any screening to be successful, use your resources. So you can start gradually and use what you have to start this very good preventive measures. If we look for the inherited metabolic disorder, as you know, it is group of single gene disorder. It is estimated to be more than 600 diseases, mostly inherited as autosomal recessive disorders, and the mutations of these genes usually leads to problem with the enzyme or cofactor synthesis or transporter of certain metabolites. As you know, also it accounts for serious morbidity, especially among pediatric population. As you know, also the clinical diagnosis is very difficult, as well as the common biochemical test, and it is non-specific, like blood gases and liver function test and other tests. However, if you want to diagnose these diseases, you have to look for this very simple pathway to understand how you diagnose them. So A go to B and B to C. If there is, this is reaction needs enzyme 2, the enzyme is in the DNA, in the code in the DNA. So if there is mutation here, you have abnormal enzyme. This will be a block here. If there is a block in this pathway, B will be accumulated, as will maybe A or D. So if you look for A, B, and D, this is called identification of biochemical markers. And this is, you can use technique like tandem MS or gas chromatography or other assay to look for this A, B, and D. The other way is to go to the enzyme itself, and this is called enzyme assay or enzymology, and you can measure the activity of the enzyme. As I said, the enzyme coded in DNA, so you can go to molecular genetics and you look for this, the mutation of this enzyme or this genes, and you can diagnose. So this is the only 3 ways in general to diagnose inherited metabolic diseases. So this is the principle of diagnosis as well as the screening. So if you want to screen, you can look for the same principles. To diagnose inherited metabolic disorder, you have to have one of those 2 things, either high index of suspicion, and this is, I call it case findings, or you go to a neonatal screening program. So what is the meaning of high index suspicion? I will give 2 examples here. This patient was, we were consulted to see this patient. The patient has, he was in few months with the liver failure, as you see. And I look for this patient. He has hepatomegaly, ascites, and so on. Of course, I ask for gas chromatography, and I see the metabolites of galactose. This is the normal control, and this is the patient. So I go back to this patient and I look to the eye, and this is the important of the exam, and he has cataract. So I know this is galactosemia because of this. So this is the patient, and this is few months after galactose-free diet. And what happened? This is actually the ankle. So the ankle, there is no face here, as you see. But however, he is the one who is holding the child. So this ankle, actually, it is an interesting story. He brought his child here in my clinic without appointment, and he told me, "Doctor, my child is having galactosemia." So he is the one who diagnosed this, because he know the disease from the, the other baby. So this is the liver ultrasound of this patient. As you see, hepatomegaly with echogenicity. What we did, we put again the patient in galactose-free diet, and as you see, the liver and the spleen goes down with time. So this patient, without really high index of suspicion, and you look for these diseases, you will miss the patient and he will die from liver failure. This is another patient who is almost at that time at 14 years of age, and she was referred to us with mental retardation. And this is her tandem MS, as you see. This is the normal, and she has a peak of 222. This is a peak of phenylalanine. So the patient definitely has phenylketonuria. The interesting thing, the mother brought this child in future with her to the clinic, and she had appointment with cardiology at that time. So I asked her, is she okay? She said yes. However, she has problem in the school in mathematics. She was in the first degree grade school, and I screened this child, and she has PKU. So we give counseling and other preventive measures. However, in the future, she was brought this child to my clinic also. I asked her, is she okay? She said yes. I told her, any problem? No. And she said this word. She said, I challenge you if this patient is having PKU. However, I examined this patient again, and she has phenylketonuria. So 3 siblings, all of them, they have PKU. If we go to the history, of course, the credit will go to Dr. Guthrie, and the Guthrie card came from his name. So Robert Guthrie in 1961 established the newborn screening for PKU, and it was spread over the world since that time to Canada and so on. However, the principle of the early newborn screening is bioinhibition assay. So it is bacterial test. So it is one test for one disease. So so this is, if we go to the milestone in the kingdom, this technique, the Guthrie test, bioinhibition assay, started in our hospital, Riyadh, in 1980. So at that time, we screen every baby for PKU. Then an advisory committee established in 1989. The area of tandem MS to screen many diseases by one test started in 1990. And then we did this study to convince Ministry of Health at that time to start newborn screening. We wrote a proposal in 2001, and the program established by royal order in 2005. Credit goes initially, to be fair with everybody, to Dr. Al-Naim and Dr. Nasser Al-Jirayan in university. They were established the test for newborn screening for hypothyroidism, and they look for hypothyroidism, the incidence here in one paper. And at that time, this is the published paper, they saved like 500 baby during years of that time from congenital hypothyroidism. So what is the bioinhibition assay? It is bacteria, it is agar, and this is bacteria inhibited by antibiotic. This is the bacteria. So, however, this bacteria needs to grow certain metabolites, like in phenylketonuria, they need phenylalanine. So this bacteria inhibited by antibiotic. However, if there is phenylalanine in the blood, it will grow. So this patient has high or elevated phenylalanine, so the bacteria grow around this spot and also here. So this is, we know this is a screening test, but as you can imagine, it is not specific. So it is one test for one disease established by PKU. Then you can inhibit the bacteria that needs certain metabolites, so you can do as many tests as you want for many diseases. So this is the principle of Guthrie test at the beginning, and you can imagine how it is, it has like low specificity, low sensitivity. It needs a lot of time for analysis and so on. The area of tandem MS spectrometry was established in 1990 by this man, David Millington. He is pharmacologist actually, and he is interested in toxicology. He visited our hospital at that time, actually King Faisal at that time, one of the hospital that look for metabolites in urine, like what happened in toxicology. And from that time, the area of tandem MS started. Guthrie Award was given to Dr. Millington, this one, and Dr. Muhammad Rashid, who was working with us at that time at King Faisal, and he did a lot really for establishing newborn screening in the kingdom. So basically, this is the machine. You put the sample. There is mass analyzer here, and then collagen, and another mass analyzer here, and this is connected to computer, and you will find all metabolites by this technique in the blood or urine or other physiological fluids. So the good things about tandem MS, it is automated samples. It is automated, also computerized system. So it is one test for many diseases, very short analytical time, sensitive and specific, and very speedy. So one technician can do like 500 samples per day. If we look to another technique called mass spectrometry, gas chromatography, mass spectrometry, used by Tanaka, who was worked at Yale. He died already, and I worked with him really. Tanaka, he is the one who established or discovered isovaleric acidemia. So this technique, you can look for organic acid in the urine, and this technique is good for confirmation of diagnosis, because you take a lot of time to do this test. So it is not good for screening. However, it is good to confirm the diagnosis. If we go to newborn screening in the kingdom, you know, this is the picture. Most of these people died. This is Muhammad Rashid. Dr. Ozan already died. This is the Dr. Jabarti, and Dr. Al-Barzugo, who died also, Dr. Al-Sideri, all of this group, and I am here in the back. At that time, we discussed, or they discussed establishing this program. I am here, I thinking really it is good idea to do something for this country. So we started with this pilot study in 95 to 98. I don't want to go to the method and whatever. However, we screened like thousands of baby after birth. We put inclusion and exclusion criteria. We take blood from the heel of the patients within 48 hours, and they send it to our lab, and we do the test. So this is the typical dry sample in filter paper that's sent to us by mail. However, you will find a lot of mistakes, sometimes even we received paper without blood, sometimes the nurse put it in the envelope and send it, and there is no blood. However, we look for this study at the end. We screened more than 27,000 baby, and there was 20 positive cases. We confirmed that by gas chromatography, and this gives a frequency of 1 affected newborn among like 1,381 baby. So this is the initial study. After we expand the screening, the incidence was of frequency 1 affected among 900. However, if you compare this with other countries like USA, Australia, Germany, we are at least 4 to 5 times more than these countries. So, but in 2001, we sent a proposal, me and Muhammad Rashid, to Ministry of Health to start newborn screening in the kingdom. Everybody, a lot of committee after committee, till it was approved by royal order in 2005. It was in phases, the program in 3 phases. And we used to do this test at King Faisal Specialist till 2012. However, after that, Ministry of Health did or established 3 laboratories, one in Jeddah, one in Riyadh, one in Dammam, to look for their patient. We still screen in King Faisal our patient at King Faisal and some private hospital and some other governmental hospital. So the screening include 17 diseases now, metabolic diseases, as you see. However, it includes two endocrine diseases, congenital hypothyroidism, and congenital adrenal hyperplasia. So after a lot actually, and expand the data for these 17 diseases, the incidence or frequency is one affected newborn among 1,100 newborn, living newborn. This is not low number, this is high, because the mashallah المواليد في المملكة 500,000 to 600,000 newborn. So if زي ما يقولوا ضربت وسطين في الطرفين, if one affected among like 1,000, so you have 500 to 600 affected newborn for affected with one of these 17 diseases. So just imagine if we expand the newborn screening for other diseases and include other single gene disorder. So what is the future? Future, you have to look for your problems and obstacles and try to solve it, and you proceed with primary preventive program. So if something happen, you know, like this broken pencil, the important is to know how to react and make it in better shape. The mistake and problem is not this can happen. However, you have to correct your problems. There are a lot of obstacles. I don't want to discuss it now, but you know, like early discharges, difficulty of recalls, difficulty of specialists in this field. So a lot of problem really. If we look for the USA, they have you know many diseases now, reaching more than 30 diseases. This is the mandatory test that every state can do it, include everything like lysosomal storage disease, like Bombi disease. What is next? Also, you have to look to other preventive measures. So you have to establish good genetic counseling program, and you look for other preventive measures. And if you have affected newborn, if you leave them like this, you will find the family bring another newborn in future with the same problem. So you have to prevent this because newborn screening, diagnosis, and early treatment, but you cannot prevent the main disease. So the prevention, you need another program. With that program, like BGD, prenatal diagnosis, and also premarital screening. Till now, the premarital screening program in Kingdom has 2 diseases only, sickle cell and thalassemia. You can expand these diseases from our genetic map in Saudi Arabia. So if you know the genes of these diseases, most of these diseases are found there. So it is a specific disease for Saudi population, and you can add more diseases for premarital screening. For affected family, if this one affected, these other members, like this is autosomal recessive, all this normal, they have to risk to be carrier like 70%. The parents are 100% carrier. However, before doing the test, every sibling of this is 70% has risk to be a carrier. So if you leave this will get married to her cousin, and the same happen or same problem will repeat it. So you can screen all this for the same gene and identify the carrier among them and give them counseling and premarital screening before they engage in this. So what is the difference between national premarital screening program and targeted for specific family? Till now, we have sickle cell anemia and thalassemia. However, targeted genetic diseases program, you can do it for all any gene that you want to look for them. Also here, general, here targeted, here you need very large population size. Here is basically the family or tribe or whatever or area, and here testing the method, here basically biochemical test, and here molecular testing. BGD is another choice for married family. So you go to as IVF. The difference you look for, you go to the fertilized embryo, and you take one of the cell and you see if the embryo affected or not. Another technique, you go to antenatal diagnosis and you look if the baby a fetus affected or not, you can go with chorionic villus sampling at 10 to 12 weeks or amniocentesis. However, what is the problem of this? If the baby affected, you have to go to fatwa, and there is fatwa. I don't want to go to this fatwa. However, in question and answer, however, there is area for termination for many diseases. If three physicians agreed about termination. And so I look for this. I am almost finishing for newborn screening. So you can do it for early treatment, and you know your prevalence and incidence. However, you know, to go to real program, you have to go with selective premarital screening and targeted genetic diseases preventive program as a strategy, and then you go to other national program. So what is the lesson that I learned over the since I came from state in 1996? There are many things in this program. You know, you have to keep your value before and after election. It is not like this cat before election يعني كل واحد مفتح عينه, بس after election كل واحد مقفل عينه, صار رئيس خلاص. And you have to be a leader really. If you are not a leader in this program, a student in the school will say المدرسة للبيع ومعها المدير مجانا. So it is you have to be leader really in this field. You have to put right man for right job. It is not because of friendship. You have the good teamwork. Media is very important. This man look for this area. As you see from the media, it looks like this one is in here is doing the problem, but the real is this one is doing the problem. So we know this media is very important. I wrote a lot of things really in this field, in the newspaper and so on. And at the end, this is my conclusion. In our society, there is huge demand for genetic counseling and preventive measures due to high incidence of genetic diseases, especially autosomal recessive. National genetic programs for prevention should be a priority for health decision makers. Genetic counseling is the key for educating and facilitating the decision-making process for at-risk families to achieve their hope. Identifying the mutation are the most important step to offer preventive reproductive option. There will always be a challenges in counseling process and prevention of genetic diseases. To take home message, neonatal screening is a program and not a test, and you have to target your aim really, and this is also important. Never give up, do something, other people will build something in future. Thank you very much, and this is my end, and I wish it is understandable. Thank you very much.
Thank you very much, Dr. Zuhair, for this very nice presentation. We really enjoyed the story of neonatal screening from the past to future. It was full of information and updated knowledge about the importance of early detection of genetic diseases. Because we are short of time, now we move to the second distinguished speaker, Dr. Afaf.
Yes.
Dr. Afaf Bafaqi. Dr. Afaf Bafaqi is a consultant pediatric nephrologist, medical manager of Iblal Polyclinic. Throughout her work, over 23 years in many well-known hospitals, such as Soliman Faqih Hospital, Kidney Center, and Stollery Children's Hospital in Canada, she acquired the passion for diagnosis and treating complex medical diseases related to pediatric nephrology. As a consultant of pediatric nephrologist in Dr. Soliman Faqih Hospital, she had the opportunity to initiate the pediatric hemodialysis and peritoneal dialysis and continuous renal replacement therapy in the PICU. In addition, she presented many scientific presentations about the pediatric nephrology in many conferences. And on the other hand, she served as a member of MOH Committee for Pediatric Renal Failure Program, devising plans including proposals and modules for hospitals in the Western region. Moreover, she has established the medical part of the Iblal Polyclinic from scratch through her role as a medical manager. Dr. Afaf, here's Mike. The floor is yours.
Okay, thank you very much for this. This is a very nice introduction, and I would like to thank the group of Germany of hospitals and Dr. Fawzia and Dr. Muhammad for inviting me to present this talk about cystinosis in your webinar. So first of all, we're gonna inshallah to go through the introduction, pathogenesis, diagnosis, treatment, and prognosis, and then we'll talk about the summary about cystinosis. So it's the most common hereditary disorder of renal Fanconi. I don't know the sign here. It's not clear. I cannot, this picture, cannot read it here. Just 1 minute.
Take your time.
أيوة. أيوة. Okay, good. So it's most common hereditary causes of renal Fanconi syndrome in children, and it is an autosomal recessive disorder, lysosomal storage disorder, caused by mutation in the CTNS gene. CTNS gene encodes for the carrier of protein cystinosine, which is acting as a carrier for cysteine to get rid of this amino acid outside of the lysosome. If this cystinosine is not working, so that leads to accumulation of cysteine within the lysosome and affect all the cells of the body. The epidemiology, it's actually the incidence, annual incidence estimated at 1 per 100,000 to 200,000 newborns. The prevalence is actually 1 to 9 per 1 million. But the accurate statistical data about this incidence in regions with high consanguinity, such as Middle East and North Africa, are still lacking. So we have three forms of this disease. The most common form is around, which is acting which is called infantile nephropathic cystinosis. It's account for 95% of the cases. Started very early, even the damage will start in utero. And the second presentation can be in juvenile. It's called in childhood. It's called juvenile nephropathic cystinosis. It's account around 5%. The last one, which is rare, it's non-nephropathic cystinosis, which is mainly ocular manifestation. This started at adulthood or the adult age. The clinical description and complication. As I said, it's a multi-system disease, lysosomal disorder, but started mainly at the beginning with renal manifestation, and then will affect the other organs and give us extrarenal manifestation. Kidney is the first organ affected by cystinosis. And the pathogenesis of kidney disease and cystinosis, actually, we know that started in the proximal tubule, and usually they are presented with a picture of a straightforward Fanconi syndrome. But actually also, this affects also the podocyte, and the patient will present with glomerular proteinuria, focal segmental glomerulosclerosis, and renal interstitial inflammation, fibrosis, and by end-stage renal failure. Renal manifestation can start with, as I said, renal Fanconi syndrome, then end-stage renal failure at 10 years of old. The infantile nephropathic cystinosis, as I said before, it starts in utero. This is a very nice slide showing us that this patient usually starting to dump amino acid within the urine within the first month of life, then glucoseuria, phosphaturia, renal bicarb. The full-blown picture of Fanconi syndrome will start at 6 months to 8 months. These patients usually present with failure to thrive, polyuria, polydipsia, episodes of severe dehydration, electrolyte imbalance, and vomiting, constipation, rickets. Why rickets? Because they are losing calcium and phosphate, and also the synthesis of the active form of vitamin D in the kidney also are impaired. The cases that I saw with the rickets, usually they have knee valgus rather than bowing, which is really severe. So these patients usually, they are losing everything like amino acid, sodium, potassium, bicarb, magnesium, carnitine, calcium, phosphate, glucose, low molecular weight to intermediate molecular weight of protein. So when you think, if you have patient having a picture of metabolic acidosis with normal anion gap, with some electrolyte impairment like hypokalemia, hyponatremia, first of all, do urine analysis. You're gonna see how glucose urea and amino acid urea or proteinuria. Search for urine electrolytes, do calcium creatinine ratio, it will be high. Do TMP, which is called renal tubular maximum reabsorption phosphate per liter of GFR. Usually it is low because the absorption of phosphate is low. Uric acid creatinine ratio is high, and protein electrophoresis in urine will be also high. This is a message for everyone that when you see patient having picture of proximal renal tubular acidosis, first of all, you should put in your mind that this is cystinosis, still prove otherwise, because this is the most common causes of RTA proximal type. Of course, you have to go through this as a differential diagnosis, but this patient usually having another problem like high liver enzyme, hepatomegaly, hypoglycemia, or started late, or having CNS manifestation like in Lowe syndrome or mitochondrial disorder. How to diagnose this? First of all, you have to have a very clinical suspicion. Because if you don't have clinical suspicion, you will not look for it. You have really have a suspicion about this disease. If you see patient having Fanconi syndrome, if you see patient having eye complaint, photophobia, if you see patient having glucosuria, proteinuria, we don't know the reason, check for the low molecular weight proteins. If it's high, immediately think about cystinosis. Also, pseudo-Bartter syndrome with electrolyte loss. They said it's rare, but actually I saw one case like this presented or diagnosed as a Bartter syndrome, but this patient was having severe hypophosphatemic rickets and was treated in the endocrine clinic as a case of hypophosphatemic rickets with calcium and vitamin D, with frequent admission to the hospital as a case of gastroenteritis. And every time we were seeing this patient having metabolic alkalosis. At the beginning, we thought that it's because of contracted fluid or because of progressive vomiting, but it was resistant even after hydration. So if you think of this, if you think about cystinosis, immediately send this patient for the ophthalmology to look for cystine crystals. Usually it's positive and it's pathognomonic if the age of the patient is more than 1 year. This is a picture of the eye. You're gonna see this crystal deposition of the cystine. It's really pathognomonic. There is no other differential diagnosis for this change. Then send for cystine level in the granulocyte. Usually this one, the patient having high or the level of cystine more than 2 nanomole per half cystine per milligram protein. It's a special test. They are doing it in a special centers to measure the amount of cystine crystals within the granulocyte. Of course, you can do molecular analysis go directly to see the gene of CTN. This is the extrarenal manifestation. As I said, renal is the first part affected, then the eyes. Of course, they're gonna have also hypothyroidism later on, and GIT, and they're gonna have also diabetes, male infertility, liver problem, muscle myopathy, also CNS. Before, we were not seeing the extrarenal manifestation because the life expectancy of cystinosis patient was only 10 years. So at the beginning, the patient will have tubulopathy, Fanconi syndrome, CKD, end-stage renal failure, and then they are dying because there was no treatment and no proper dialysis and transplantation. With improvement of the dialysis and transplantation program and the discovery of the treatment, we were starting now to see the complication of this disease after the transplantation, not because of the deposition of these crystals in the renal system, no, because of the deposition to the other organ, which is like the muscle myopathy, blindness due to retinal deposition, diabetes, hypogonadism, CNS manifestation, and lung problem. So how can we manage this patient? We have to do two things, hand to hand. Symptomatic treatment and cysteine depleting therapy, what we are calling it CDT. Symptomatic treatment is very important, that although we are treating it with the medication, this patient usually they are losing huge amount of fluid. So we have to make sure that they have good access of water, avoid dehydration, give him nutritional support, and give him the supplement of electrolyte that which they are usually losing it, like potassium citrate, sodium bicarb, and potassium chloride. Treatment and prevention of rickets, giving him the active form of vitamin D and replace the phosphate deficiency. Copper deficiency also give him, and if they have severe polyuria, you can start with indomethacin, but you have to be very cautious because of the side effect of this medication. In patients with adequate metabolic control but persistent poor growth, you can start him with growth hormone, although the level of growth hormone, this patient usually normal, but just to push up his growth. What about cysteine depleting therapy? It aims to deplete lysosomal cysteine in all body cells and tissue. Cysteamine has been available as a commercial drug since 1997 in immediate release, as an immediate release formulation, because it has to be strict Q6 hours to be taken. A new delayed release formulation has been available since 2013 in USA and since 2014 in Europe, with must only be administered, which must only be administered twice daily. This is the action actually of cysteamine, that is bind to cysteine, which is within the lysosome. But this way, we can release cysteine outside the lysosomal part. But as you have to know that we are bypassing the action of the cystinosine, the carrier. And by the time they discover this protein is not acting only to transport the cysteine outside the lysosome, it has another complex function of within the cell or the lysosome. So any defect of this protein, the patient usually will have still persistent disease, even if we treat him with cysteamine to release cysteine outside the lysosome. Cysteine depleting therapy, it has a systemic, we have to give this patient systemic administration through systemic administration, and we have to give him also eye drops because systemic medication will not reach to the cornea. We have two types, the short acting or the immediate release called cystagon. We have to start gradually and then increase the dose according to the protocol to avoid the side effect. And there is another one called Procysp, the new medication, which is delayed release cysteamine. Actually very expensive, and it's available only in high institution centers. This is a study showing the effect of cysteamine treatment in improvement of the kidney function. Like here, if we didn't treat the patient, by the end of 10 years, they're gonna have renal failure, but partial treated, we can postpone it to 16 years. If we treated him adequately, we can maintain him for a time of around 10 to 15 years. The problem of this medication is the side effect of this medication is really huge, which is GIT upset. That's why we can give him also PPI, proton pump inhibitor. And actually the patient and the parents complaining from this medication that it give us very bad breath and bad smell. Because of the strict medication, because of the strict regimen that we have to use this medication, Q6 hours, it's really difficult. So there is a study showing that only 1/3 of these patients have a good compliance for this medication. This picture showing that early diagnosis and early treatment is better than late. Imagine this boy is his age is 2.5 years, and this boy is 4.5 years. Both of them having cystinosis, siblings. The younger one started the treatment at 3 months of his age. The older one started at 20 months of his age. So the younger one, because of the medication was started early, they improved in their growth. He improved in his growth. This is another study showing the effect of cysteamine in extrarenal manifestation. But this is the age is quite limited from 21 to 30 years. Improvement of diabetes, improvement in myopathy, limiting or decreasing the pulmonary function, and decreasing the percentage of hypothyroidism. This medication need to be monitored. Actually, if we decided to start this patient on cysteine depleting therapy, we have to monitor Q 3 months to see the dose that is appropriate for this patient by doing WBC cysteine assay to measure the amount of cysteine within the granulocyte, and it should be less than 1 nanomole per half cysteine per milligram of protein. But actually, because of this assay is really difficult, it's not available in every center, and it's difficult to transfer the sample to another center. The test is really fragile. Now the research workers working on the inflammatory release of macrophage called ketotriosidase, released from the macrophage under the effect of cysteine crystals. They found it very sensitive and easy to be used, and we can apply it in each center, but still under study. Another study working also, they are working in reflectance confocal microscopy of the skin machine, non-invasive. They can see the deposition of the crystals of cysteine within the dermis. The message here to know that if we are treating this patient, we are improving the prognosis, but we cannot stop renal failure. We can delay it up to 16 years, but still we are facing patient having renal failure. So from the study, it showed that peritoneal dialysis and hemodialysis are suitable for cystinosis patient. And no evidence that cysteamine does not adjust, no evidence that cysteamine dose adjustment is required in patient on dialysis. If we do transplantation for this patient, actually a very nice study showed that the graft survival is really excellent, and we don't need to do nephrectomy for the native kidney, and then immunosuppressive medication will be the same. The disease does not reoccur in the graft kidney because they have already the carrier cystinosine in the kidney. Parents are accepted as a kidney donors. And cysteamine treatment has to be restarted when patient can take oral medication after transplantation to continue and continue for life to prevent extrarenal manifestation. This is a nice study done for patient having transplantation. Actually, they found that a patient with cystinosis doing better in graft survival than non-cystinotic patient. So the prognosis, cysteamine has improved the prognosis of cystinosis patient dramatically, but it's still not a curative therapy. Dysfunction of the lysosome transport protein cystinosine lead to several distributed intracellular and interactions that can be corrected by depleting cysteine from the lysosomal compartment. With the increased life expectancy, more long-term complications are being recognized and reported. So the future prospects, the search for the therapeutic substitutes for cysteamine is now strongly ongoing. The therapeutic focus now is not just CDT, but also how to elevate other possible harmful pathogenic mechanisms. The most promising approach to cure cystinosis is to the transplantation of hematopoietic CTN carrying stem cells, but still it's in vitro. So take home message that you have very high level of suspicion in patient having renal Fanconi syndrome or unexplained proteinuria and glucoseuria, eye problem photophobia, pain in the eye. Examine, if you see like this, examine the blood to see the cysteine level within the white blood cell, do DNA test. Treatment with cysteamine remain the main therapy. Early administration improve the kidney function prognosis. Treatment should be continued after kidney transplantation to protect extrarenal organ. Novel therapies are still under clinical trial. Thank you for your listening.
Thank you very much, Dr. Afaf, for this excellent presentation. Actually, it shed light on and actually covered all the needed aspects of diagnosis and management of cystinosis. Now we shift to the third speaker. I'm really glad to introduce our third distinguished speaker, Dr. Tagreed Shuaib. She's going to give us a presentation about phenylketonuria. Dr. Tagreed is an assistant professor of pediatrics at King Abdulaziz University. She's a consultant pediatrician, clinical biochemical geneticist. She's a graduate of the King Abdulaziz University School. Clinical genetics fellowship. She got her clinical genetic fellowship at King Abdulaziz University Specialist Hospital in Riyadh, and she is now the head of the newborn screening unit in King Abdulaziz University Hospital. Dr. Tagreed, can proceed.
Assalamu alaikum. I would like to thank the organizing committee for this kind invitation and welcome our audience. I would like to ask Dr. Afaf just to stop sharing so I can start sharing my screen, please.
Yes. Okay. Yeah.
My talk today will be about phenylketonuria, which is one of the inborn errors of metabolism. And these are the aspects that we'll go through in my talk. So to start with, let's define what do you mean by phenylketonuria. It's an autosomal recessive disorder like the rest of inborn errors of metabolism. It occurs in an incident, the global incidence, in 1 in 15,000 people. The disease is about elevation of phenylalanine and deficiency of tyrosine, secondary to deficiency of phenylalanine hydroxylase. And the problem is that phenylalanine is a neurotoxic agent, and it requires a lifelong therapy with low Phe diet and high tyrosine diet. The biochemical reaction takes place mainly in the liver and kidney with the help of an enzyme called phenylalanine hydroxylase and the help of a cofactor, which is the tetrahydrobiopterin. Phenylalanine will be converted to tyrosine, which is a precursor for dopamine and melanin. So the disorder results in prevention of this biochemical reaction, resulting in elevation of phenylalanine, which has a neurotoxic effect, and deficiency of tyrosine, which is essential, so leading to deficiency of dopamine and melanin. So when was the PKU first recognized? Was as early as 1934. Dr. Fallings discovered the PKU when a mother brought her 2 handicapped kids to him because they have abnormal urine odor. And he applied what they call the ferric chloride test, and the urine of affected kids were turned green. So he identified that this color came from phenylpyruvic acid. But he managed to diagnose, but the treatment took some time. In 1953, Dr. Horst Pickel discovered the first therapy for PKU, which is the dietary modification by removing the phenylalanine from the diet. So they managed to diagnose, treat, but the tool for screening for phenylalanine level took time till 1960, when Guthrie started the bacterial inhibition assay, which can measure phenylalanine. So they had the complete diagnosis, management, and screening, but they wanted to give a better outcome. So the better outcome will be by early diagnosis, and the early diagnosis for this disorder should be as early as the neonatal period. So Guthrie started newborn screening in the United States in 1962, and then the management of PKU were developing. The gene for phenylalanine hydroxylase was recognized in 1985. And in 2007, a new concept in managing patients with PKU, which is the use of the cofactor, the tetrahydrobiopterin, was started. And the latest intervention in patients with PKU is the enzyme substitution, which was recently approved in 2018, but it's only limited for adult patients. So is PKU common in Saudi? Well, the study of newborn screening data in Saudi, this is a published paper by Dr. Majd al-Fadl and his group, and they found that the incident in Saudi is 1 in 14,000. This is for Riyadh area. And in the mom, they found a relatively higher incident with reaching 1 in 11,000. Another study by Mitwalli et al. And his group looked at all Arab countries. The incident in Saudi and Emirates were similar, but the highest were found in Turkey and Iraq, which is similar to some of the European countries, Scotland and Czechoslovakia, where the incident reached up to 1 in 5,000. So go back to the genetic of PKU. It's a single gene disorder. It's caused by a single gene, but there are plenty of mutations reaching up to more than 1,000, giving a different clinical phenotype. Some of those mutations might abolish the enzyme level, giving you a severe phenotype, and some mutation give you a milder reduction in the enzyme activity, leading to asymptomatic or a benign phenotype of PKU. And also genotype can predict if a patient will be responding to the cofactor, which can help in the disease management of patients with PKU. This study looked at the patient's clinical phenotype, and they compared their clinical phenotype severity to the gene mutation severity. So they found that severe mutation, like here in the dark color, mostly seen in patients with a severe phenotype or the classical, but still the severe mutation was seen in some asymptomatic patient and mildly symptomatic patient, so which tells you that the genotype phenotype correlation is not 100% in patient with PKU, but it's relatively as high as 70%. So as we mentioned, the mutation can give complete enzyme deficiency. So before you get the genetic result, you can classify patients based on the phenylalanine level. So if you have a complete enzyme deficiency, classically they present you in the newborn screening or when you test them the first time for by checking their plasma amino acid, the level usually exceed 1,200 micromole. Patient with partial deficiency, the level usually range between 600 and 1,000. Partial enzyme deficiency usually also can be asymptomatic when the level ranges between 120 and 360. So usually we go by this clinical classification, and we correlate that with their genetic classification. So how does phenylalanine cause the problem in the brain and result in the intellectual disability? Elevation of phenylalanine in the blood crosses the blood-brain barrier through a transporter in the blood-brain barrier, and inside the brain, it interferes with the pyruvate kinase activity, and it damages the myelin sheet, and it inhibits tryptophan and tyrosine activity in the brain, so which are essential neurotransmitter, which result in the neuropsychiatric symptoms and behavioral symptom and intellectual disability. So how would a patient manifest? Classically, a patient, if left untreated, they usually manifest with irreversible intellectual disability, behavioral problems, seizure disorder, and the reduction in the IQ level usually correlate with the phenylalanine level. So for each 100 micromole increase in phenylalanine, the reduction in IQ is by 1.3 to 3.1. But a severe phenotype, if got treated early, they might have a normal IQ if you keep monitoring their Phe level and maintain it within normal. Some adults, they tend to relax their diet when they grow older. So that is really associated with the reduction in the IQ level. There are studies also mentioning that even patients who are classical or the severe phenotype, if they got treated and they stick to the diet, some might show language skills, memory, or learning skills problem as an adult, in spite of having adherence to the diet. There is a tendency that adults, they relax their diet, but this is associated with problem. That's why we encourage treatment even during adulthood period, because it's associated with a major neurological behavioral problem. Some of these problems might be reversible if patient go back to treatment. In a patient with mild, classically the moderate, which is the 600 to 1,000, they tend to have symptoms, if not treated, similar to the classical PKU. The mild type, which is 360 to 600, there are reports that if you leave them untreated, they might not show any symptoms as during childhood period, but they might manifest psychiatric manifestation as adulthood. That's why the recommendation is to treat any figure above 360. The mild hyperphagia, which is the mild type or the benign type of PKU, where the level never exceed 360, they usually never present. We identify them by newborn screening, and they don't require treatment, and even they don't have any risk when they grow up as an adult. Clinical manifestation, usually if you see them during the neonatal period and even early infancy, they look normal. Although some mention that they might have tendency to be IUGR or microcephalic. The microcephaly sometimes takes time to show. It depends on the disease severity. That's why we don't rely on clinical feature early in life. We go by the newborn screening. So the diagnosis, as we mentioned, we don't wait for the clinical feature to diagnose. The best time to diagnose PKU is pre-symptomatic. And this pre-symptomatic can be achieved except with the newborn screening. So newborn screening usually done at 24 hours of age. And the lab will call you for the positive case if the level of phenylalanine exceeds 120. But usually you have to repeat because sometimes it's transient. So if the elevation exceeds 360, you are most likely in the moderate to severe phenotype where you have to start dietary therapy. If the level continue to be 120 to 360, mostly you're dealing with the benign hyperphagia or a transient hyperphagia or a different disorder other than PKU called the tetrahydrobiopterin disorder. So in this category, you don't have to treat the patient. We just go with monitoring. So if the newborn screening is 100% sensitive for PKU, you never miss a case by newborn screening. Plasma amino acid is the second test to be done after a positive newborn screening, looking at the phenylalanine level and the tyrosine, phenyl to tyrosine ratio. And if you have mild elevation, tetrahydrobiopterin or PH4 cofactor deficiency is another differential other than PKU. So you need to do a workup for that in order not to miss this disorder. Then you have to go for genetic testing to classify the patient and predict their responsiveness. You can go with mutation analysis if you have ethnicity where a mutation is known, or you could go for full gene sequencing and reading, which is more sensitive. If you do MRI on patient with PKU, you find white matter disease, as you mentioned. We mentioned previously that the pathophysiology, there is injury to the myelin production in the brain. And there are patients also who had normal PKU phenylalanine level, and they did show white matter changes. So how can we manage patients with PKU? The goal of the treatment is to normalize phenyl level and improve tyrosine level, maintain optimal growth, prevention of cognitive deficit. So if you can handle the case, treat it. If you can't, you have to refer the case to medical genetic, metabolic dietitian. You go for the genotype, and definitely once you establish the treatment, you have to go for monitoring and genetic counseling, as this is one of the hereditary disorder with tendency for recurrence. This is the guideline by American and the European guidelines. You have to maintain phenylalanine level within 120 to 360 in the first 12 years of life, and the same thing for after 12 years, except for the European, they tend to have a higher level during after 12 years of life, of age, I mean. For patients with hyperphagia, usually we don't treat, and they tend to keep their level within 150 to 360, and they just require monthly and annual monitoring for this level. So we have to assess the tolerance for phenylalanine, which is how much phenylalanine those patients can take, and they keep the level in the blood within acceptable range. So, well, it depends on the severity of the patient. If the patient is the classical, where the level exceeds 1,200, they usually don't tolerate more than 200 to 350 milligram. Where the milder the disease, the higher the tolerance. And in patients with hyperphagia, they usually take normal protein and normal requirement for phenylalanine. So early after diagnosis in infancy or neonatal period, usually we start them on a special milk formula, has 0 level of phenylalanine. We combined with that a regular milk formula or breast milk. And when they grow older, there are food products where it has a low protein, or they can definitely the vegetables and fruits with no protein also can be added. You have to be careful because we cut their protein, not to have vitamin deficiency or calcium deficiency. So they have to check them and supplement them when needed. There is another amino acid that can be given to those patients called large natural amino acid in addition to the milk formula and the diet. It competes with phenylalanine and prevent its entry to the blood-brain barrier and reduce the toxicity in the brain and really improve the cognitive outcomes, especially in poorly compliant adult. The cofactor is also another therapy in addition to the dietary restriction. Sometimes not all patients actually are responsive, so you have to check first responsiveness by giving a loading test of 10 to 20, then measure phenylalanine. If you have a reduction by 30%, actually the patient is responsive and he would benefit from continuing on Covan or tetrahydrobiopterin, and that will give him more chance to increase the tolerance for phenylalanine. Enzyme substitution is one of the latest therapy, but only approved for adult. It's highly immunogenic. It was recently approved in 2018. That's why the introduction of the enzyme need to be gradual over 3 months till they reach the maximum dose, which is 20 milligram daily. But early they have to go gradually with a very small dose. It's given sub-Q like insulin. The problem is the immunogenicity. They have high risk of hypersensitivity reactions, especially in the first 6 months of starting the therapy, which tend to get less when the time comes. And this enzyme, majority who do good respond, they take normal amount of protein without restriction. In addition to the dietary management and the pharmacological treatment, monitoring of development, executive function behavior is something that you have to check routinely in those patients or whenever is needed if they're symptomatic. So we'll take some case scenario. The first case was a boy presented to my clinic at the age of 24 months. He was a Saudi, unfortunately missed the newborn screening. He presented with early developmental delay, seizure disorder, eczema. Parents were consanguineous. Clinically, he had small head with fair hair and skin, hypotonia with increased reflexes. His phenylalanine level when screened was 1,900. Mutation analysis, he was homozygous for a mild mutation. But his diagnosis was a classical PKU and untreated. After treatment, he was seizure-free and he was gaining his milestone, but he continued to have elements of developmental delay. So this is just to tell you that the clinical phenotype does not always go with the genetic. So the biochemically he's severe, but genetically he was mild, which it gives you the idea why there is poor clinical phenotypic genotype phenotype correlation. The second case is another case who presented 5 days after delivery when a newborn screening lab called us for high phenylalanine of 300 and the repeated level was 1,700. So this is another severe phenotype based on the level. Parents were consanguineous. He was started on the diet and was checked also for tetrahydrobiopterin responsiveness, but he was not responding. So currently he's 5 years old with normal development and normal cognitive function. So this is the classical PKU of the same severity like the previous case, but he was early treated. This case was 2-month-old girl found to have high Phe level in newborn screening, reaching up to 166. Follow-up readings was ranging between 180 to 230. So this is by definition mild hyperphagia. Parents were not consanguineous. The genetic testing showed two mutations. One was known to cause hyperphagia, and the other one was known to cause mild phenotype. So this patient was a classical hyperphenylalaninemia. She's doing perfectly well. She's currently 1 year, never symptomatic, and she was not on treatment. So there is a good correlation here between the phenotype and her genotype. So to wrap up, phenylketonuria is seen in Saudi with an incidence of 1 in 15,000. And if you have 600 deliveries per year, so we expect to see at least 40 cases per year. Newborn screening has 100% sensitivity for diagnosing, and it's the right of every child to be checked for this disorder. Treatment should be initiated as soon as possible to prevent brain damage. The biggest challenge is living with lifelong therapy with low-fee diet in those patients. Identifying the disease phenotype either from the genotype or phe level guide your management. Enzyme replacement actually is a promising cure for adult patients. And by that, I would conclude and thank you.
Thank you very much. أنا عايز أقول ختامه مسك بس I don't know the actual translation. What does it mean? But excellent end. It's a very elegant presentation done by Dr. Tagreed, and I think we all benefited a lot. I think we have some time for question and answers, very few questions, and I leave the mic for Dr. Fawzia to handle the question and answer part.
Assalamu alaikum again. The first questions for, I think Dr. Zahir went for praying. The first question from Dr. Fawzia Arif. She's a consultant neonatologist in Saudi German Hospital. She's commenting why most of treatment of those disease and the products not available in the market or the hospital, and still there are a lot of patients diagnosed. Can we start with Dr. Tagreed, please?
Which treatment? Which treatment? She means milk formula?
She's like for, yes, not only the formula. She's talking about the formula, I think, and the medications. For example, BS4 for, yes,
Yeah.
yes. For.
Well, I don't have an answer for that, actually. Well, these medications are expensive. But, well, sometimes you need to have a good number of patients to get this therapy. But I don't know really. Well, maybe someone like you, someone in higher ministry who really dealt with these requests can answer this question. For us, maybe we have difficulty in providing the milk formula for everyone, and we can't really have it regularly available. Sometimes we went out of stock for a while, then we get the access to the formula again. Well, but yeah, I guess it's the cost of this problem and lack of support. Majority of a common disease gets supported, like cardiac, renal disease, especially when you correlate that with a good outcome. The presence of societies to support this group of disorders. So actually the support is very limited for patients with inborn metabolism, which still rare compared to common disorder like cancer, cardiac, and renal diseases. So maybe if we get supported, and don't rely just on the ministry or local treating centers to provide this. Yeah, but the main reason is the cost, and those patients are really rare. We don't see it much.
Okay, regarding the Ministry of Health, I think all the or most of the formulas are available because we have newborn screening, and even the medications are available by what we call direct purchasing, patients by patient. But in the private sector, things are different. But in Ministry of Health, when I used to work there are a lot of patients receiving all the medications. Okay, we have another question. Dr. Afaf, do you want to comment on that?
For the formula?
Availability of medications and formula?
Well, I will talk from my section, like in cystinosis, actually, we need, actually, we're asking for cystagone. Actually, in the private sector, it was available to direct from the, also it was provided by the insurance. But the other medication, which is called Procesp, is really very, very expensive, and it's not available. And I think it's not available also in the Ministry of Health in Jeddah. I don't know, in the outside, and also in the specialist hospital.
Okay, fine. There is one question from Dr. Sousan Daffa. She's a consultant neonatologist in Aya Hospital. Her question is for Dr. Afaf. When is the best time to diagnose cystinosis, and what is the prognosis?
Yes, the best time to diagnose, as I said, is early as possible. That you can diagnose this in when antenatally, as Dr. Rahbini mentioned, by two ways: either taking a sample from the chorionic villi or from the amniotic fluid, looking to see the accumulation of cystine crystals within these cells, or doing a DNA test. And as I said in the lecture, early diagnosis and early treatment, of course, is better than late. The prognosis also, I mentioned before, that without treatment, without transplantation, the life expectancy was up to 10 years maximum. But with treatment and transplantation, we are expanding the life expectancy up to 50 years, but not longer. But still, although we are using this medication and we are doing good transplant, but still the complication of the extrarenal manifestation, we are seeing it later on. Actually, it's not in pediatric age, but in adult age, that diabetes, CNS manifestation, myopathy. As I said, this medication is not a treatment of this patient yet. Still, we are looking for a novel therapy to have a complete treatment for this patient.
Okay, Dr. Afaf, me and Dr. Sousan shared one patient who the result of newborn screening came with a high cystine. Okay, and when I dig in the history, I found that the families of this patient having renal problem, a renal failure. So is it possible to have the diagnosis from newborn screening?
Yes, good question. I was looking for a newborn screening, and I was looking for different articles that the newborn screening has a specific category for all these metabolic disorders, but exactly for cystine level, it's not available yet. It's in their mind, but it's not available right now.
But it came to be high, maybe because of the spectrometry showed high cystine.
But the sensitivity is not, yes.
It was not specific, maybe, but because we took the history and found a renal problem in the family, so we thought, okay, this might guide us to the diagnosis of cystine.
Yeah, but the most specific test for this one, you just go right away to do the WBSA for this patient. It will give you a good test. Of course, the eye exam will be negative because the crystal of cystine deposition in the eye is still not yet. It takes time, up to 1 year.
Okay, there is another question for Dr. Afaf. Is the efficiency of treatment by histamine related to type of mutation in CTN's gene?
No, actually, it's as I said, the defect of this gene lead to a deficiency of protein called cystinosine, acting as a carrier for cystine crystals in the cell. But actually, the cystinosine is having another function rather than transportation. Exactly, it's a complex function. It's a complex mechanism. So when we give this patient cysteamine, we are just helping this patient to transfer this amino acid outside the lysosome. But the mechanism of inflammation within the cell is still there due to the lack of this protein called cystinosine.
Okay, there is another question for you, Dr. Afaf. With early treatment of cysteamine, how long this treatment will delay ESRD?
Good question, yes. Actually, it can delay it up to 10 years. Up to 10 years and even up to 16 years. So it's a good time. It would give us a good time. And even expanding the lifespan up to 50 years. It's really good when you start early.
Okay, thank you. There is Dr. Tagreed. There is a question actually for everyone. What are the rare diseases of amino acid disorder?
What are eh?
The rare disease of amino acid disorders.
And we usually look for what's common, not what we don't look for what's rare. Actually, all inborn errors of metabolism is considered rare, having a frequency of 1 in 15,000. So there are the common things, actually, what we screen for in the newborn screening, and the common treatable ones, those are the ones picked up early and treated, like MSUD, PKU, homocystinuria. These are the classic, common, and treatable type. There are rare types that we don't usually see, and some of them might not have available treatment, like hyperglycinemia, histidinemia. But I don't know why she's interested in the rare type. Well, you can't diagnose them. Yeah, I don't know.
Okay. I have a question for Dr. Tagreed. Do you use Covan for every patient with PKU, even the classical one?
Well, it's known that only 10% of classical show a response to tetrahydrobiopterin or Covan, but it's the recommendation, well, it's not up to me. Well, the recommendation that every patient has the right to be checked for responsiveness, because it just gives them some freedom in the diet. So there is no urgency to go for that as early as neonatal period. You can just wait for that and challenge them. The most sensitive way of challenge is the 48 hours. Others, they believe if you give a longer course, they might have a delay response early, and you give them a longer period to show the response. But it's the right of everyone to have it if it's available at your center, definitely. If you don't have it, well, refer them to a center where this challenge can be done. Majority who are sensitive are the moderate and the mild type. Rare, classical usually rarely show some response to Covan. And once some of them can predict the responsiveness by the genotype. If there are certain mutations, tend to have good responsiveness. But the most sensitive tool is not the genotype, is to go for the challenge test. I don't have it at my hospital, but I usually tell every patient that there is a cofactor that can give you better chance of taking more protein. So and not everyone show this response to this medication. And well, if they would like to go for it, yeah, I definitely refer them. But it's the right of everyone, according to the protocol. You have to check for responsiveness, and then decide to continue definitely the medication.
Thank you, Dr. Tagreed. I think we have enough questions. Dr. Mohammed?
At the end, I'm really happy to have this good number of attendees. And I'm really thankful to all the speakers for reminding us with the basics as well as the advanced information about such rare entities. We now know when to suspect and when to refer such cases. Thanks a lot, Dr. Fawzia Sharif, for organizing such nice webinars for the rare metabolic and genetic disorders. And thanks a lot for SGH for sponsoring and preparation of such webinars. That's so important for the medical community. Thank you all, and looking forward to see you maybe in the same day, next week, Friday, 17th of July, at the same time. Kindly fix your agenda, and we are looking forward to see you once again. Assalamu alaikum.
Wa alaikum assalam.
Alaikum assalam.